Thank you very much. I put this under several headings. The first was regarding communication with patients. And in vascular surgery, we're sometimes quite slow, quite bad to explain that, for instance, vascular disease is a very slow progress and that the implications for the patient's limb aren't often that bad, but the implication for the patient themselves are very serious. So for instance, intermittent claudication, less than 1% of people will require bypass if they stop smoking. 50% of people will stay the same, 25% will get better. But if they don't look after themselves, they're going to die of a heart attack or stroke with a 50% mortality rate at 10 years. And we're very poor at explaining that type of thing. We're also very poor at explaining to patients that if they come in for their balloonist stent, yeah, it's a nice quick fix, but it invariably means that they'll be coming back for ballooning and stenting for many years, and that there is a high failure rate. And there's also a failure of comprehension. And we forget this bit when we talk about communicating. When we think about communicating, I think a lot of surgeons just think about talking at people. They don't worry about what somebody actually hears. And our patients, the concept of informed consent, and I think this is across surgery, is an extremely difficult one. And trying to make sure that the patient actually understands what their consent means is very difficult. And it's very easy to talk too high to patients and not really keep it at a very, very basic level. As surgeons, we like to surge, so we don't really like to talk too much about things. But the importance of lifestyle changes in our vascular patients is incredibly important. And we know that lifestyle changes are very important across all medicine. The same lifestyle changes of watching your weight, don't smoke, drink in moderation, and exercise are the 4 things that also prevent cancer. So we're very poor at emphasizing these things. The other thing is that in vascular surgery, once you've done an intervention, or sometimes before you do an intervention such as an aortic aneurysm, the patients have to attend for surveillance scans. And if they start missing them, it doesn't require an awful lot for an aortic aneurysm to go missing. So it requires maybe a slight clerical error somewhere, a change of GP, and all of a sudden an aneurysm that was seen 2 or 3 years previously comes in ruptured. And you wonder what's happened. And the answer is it's often a really small error in the system. In communication with primary care, one of the big problems that we've had now is that we've failed to personalize relationships. And I say this across medicine in general. Everything is done by text, telephone, messaging. Nobody meets anybody anymore. Nobody actually ever meets a GP face to face. And as a result, there's not a good working relationship. It's very easy if someone's faceless to either be rude or offhand with them. If you know who they are and have to meet them regularly, then that becomes a completely different issue. And we have a failure to educate, and this is one of the things, we're very easy, and you see this around hospitals all the time, people sitting around being critical of people in primary care, being critical of things, and the answer is, well, those GPs were once medical students on your ward. If they don't know what to do with that patient, that's your fault. And if they don't know what to do and they haven't managed the patient well, why not just make sure that they're aware of the errors that were made? The big ones that happen in vascular surgery in terms of this is the failure to notify. And this is anticoagulation and dual antiplatelets. And these are repeated episodes. Once you've been a vascular surgeon for years, it's omitted drugs resulting in blocked grafts, or it's overdoses of warfarin resulting in dead patients, and it's a failure to hand over. The other thing is surveillance results, making sure that GPs are aware of things, because the good advantage is if you try to let GPs know about patients that are on surveillance, then that's a fail-safe method for you. If that patient goes missing, something happens with your system, hopefully the GP will recognize that that patient hasn't attended for surveillance. And we also fail to communicate with nursing and allied health care. So we have an awful lot of patients with wounds, chronic wounds, and A lot of vascular surgeons don't understand the funding and how wound care is carried out in the community, and are very critical about how wound care is carried out in the community. And we don't communicate well with people who are carrying out wound care in the community, and we're very quick to criticise and very slow to understand. Within secondary care, again, we have this failure to personalise. So we're very quick to be critical of someone who we've never seen, to not worry about them, because we don't know them as a person face to face. In particular, infectious diseases and rehabilitation medicine. You would think that since we have so many diabetic feet, so many infectious, so many people on our ward with infections, that we would regularly do rounds with infectious diseases. That actually doesn't happen. Similarly, because we are the people who remove legs, you would actually think that we would regularly see our amputees with the rehab people. We actually don't. Hematology oncology. Now this is a group that I have to admit we don't do a lot of work with, but unfortunately we often see their patients when they're extremely sick, or when they're running into real trouble, often towards the end of their disease. And I have to say, I find it amazing if you go in, when these patients come into my clinic, I talk to the patient, I try gently to understand their prognosis. If they've had a surgical condition, I used to be a general surgeon, I usually understand some of their prognoses. I look through the notes very, very carefully. They've documented they've had a very late stage disease. There's no documentation that they've ever had a discussion with the patient about their prognosis. And the patient seems to be completely unaware of it as well. I've had some very difficult times in my clinic, particularly when patients with very advanced cancer have been referred to me for venous stents because their cancer is actually obstructing their veins, trying to explain to the patient they've actually got recurrent cancer, and they are completely unaware. With regards to anaesthetics and operating theatre, we need to improve our communication with regard to certain things, and that's the urgency of bookings and the anaesthetic and staff requirements. A classic example is I often do a list of fistulas on a morning. I've written that it's a local anaesthetic list. The first thing I meet in the morning is the anaesthetist. In allied health, we also need to communicate well with them, because these people are critical, very critical for the discharge of our patients, and podiatry, physio and pharmacy, and we're often again very poor in liaising with them. Finally, I just want to talk about system failure. This is what results from an introduction of an electronic patient record. I go to Port Augusta, I see 30 patients, I type into EPAS, I print out all my own letters myself. I have to sign my own letters myself. At the end of the day, I have to work out what messages do I have to bring back and walk around the Royal Adelaide with. So on Tuesday then, I file, those are the 5 different people I have to go around the Royal Adelaide to find, to tell them what happened in my clinic, and it's all in EPAS, but of course they're completely unaware that it's in EPAS. In addition, we used to have a pile of case notes. You used to dictate a letter. You would then have to read your letter. So you then knew what actions you had to take. Once I've finished typing at the end of that patient, that's it over. If one of those pieces of paper goes missing, and one of those has the report that there's 2 aneurysms that need an operation, that might be the last time it's ever seen again. And so that is not I'm not saying it's a failure of EPAS, it's a failure of the system surrounding the whole thing. And that is amazing that's the amount of paper generated from having an electronic patient record. Thank you very much.